Hi, this is Dustin Nash. I'm a third-year medical student at the University of Utah, and this is my presentation as part of my family medicine clerkship, where we're looking at the risk-benefit analysis of treatment of diabetes mellitus with metformin. We'll touch on some of the issues regarding risk-benefit analyses, how they can be applied to clinical situations, and then move on to discussing some of the risks and benefits associated with metformin. Let's start out with a case presentation. Mr. B is a 65-year-old male with a past medical history notable for an MI about 20 years ago. He comes to the clinic today for ongoing follow-up with his diabetes mellitus. He also has a history of hypertension and hyperlipidemia. Looking at the electronic medical record, the patient is currently prescribed metformin, glyburide, atorvastatin, atenolol, and a daily aspirin. When asked about medication compliance, the patient states that he's currently taking 1 pill a day for each of his chronic conditions. Says he takes aspirin, glyburide, atenolol, and simvastatin. You may notice that this list differs from what was recorded in the EMR, in which he is not taking the metformin which has been prescribed. When asked why the patient is not taking the metformin, or if he has specific concerns with taking the metformin, he says that he does. He gives a sort of speech like, "Oh, you probably hate patients like me," and reports reading about on the internet possible side effects of metformin and decided that it was a risk he did not want to take. When asked which specific side effects the patient was concerned about, he doesn't really have a good answer. He says he read some things that maybe would hurt your kidneys. He read some things that it might affect other areas of his life that he could not specifically recall at the moment. He also states that he has been recently suffering from increased fatigue. He's been drinking a lot, he's been peeing a lot, and his erectile dysfunction has gotten worse. Just then you notice that the value for the hemoglobin A1C listed for today is 8.2%. So let's take a moment and reflect on what's happened. What really has occurred is that this patient has performed a risk-benefit analysis. Risk-benefit analysis is the practice of assessing the ramifications of taking or not taking an action. So we have to ask ourselves, what are the risks associated with the action? What do I stand to lose? What are the benefits of taking the action? What do I stand to gain? And then really asking ourselves, do what I stand to gain outweigh what I stand to lose? An example of this might be driving in our car to come to work. So what are risks associated with driving a car? Well, we could get in an accident. There's also the risk of the car, small as it may be, bursting into flames and us dying. These are small risks that are not likely to happen, but they must be accounted for. Benefits of taking the action is that I don't have to walk, in order to get into work. If there's an emergency, I'm able to respond to that emergency more quickly. It seems for most of us that the benefits outweigh the risk of driving a car. An important thing to remember about risk-benefit analysis is it will be most effective if our understanding of the situation and our education about the subject is more complete. If we have been fed poor information or have a poor understanding of the situation, we might not be able to appropriately weigh the risks and the benefits. And this seems to be what's happening with Mr. B. He seems to think that the risks of being treated with metformin outweigh the benefits. Let's dive into the data to really see what the risks and benefits of being treated with metformin are. So first of all, a little background on metformin. It is the first-line drug of choice for type 2 diabetes. This is an ADA grade A with an ACP strong recommendation of high-quality evidence. What it's trying to say is that we know that it works and we know that it's safe in most cases, which is why it has been placed by the first-line drug. In terms of efficacy, we can usually expect an average decrease of the hemoglobin A1C between 1.0 to 1.5 on the maximum dose of metformin. It does not typically cause weight gain, and in some cases cause weight reduction, and rarely causes hypoglycemia, which are two significant benefits over other oral hypoglycemic agents. So with such a positive recommendation, how did Mr. B arrive to the point of feeling that the risk of taking metformin, or the side effects of taking metformin, outweighed the benefit of lowering his blood sugar? Well, let's talk about the side effects first. If you typed metformin and side effects into an internet search browser, or if you looked at the package insert, what you get is this long list of possible side effects. I mean, everything under the sun can be caused by what seems almost any drug, and it doesn't seem to be any way to categorize what I, myself, as a patient might experience. Let's delve into the list of side effects a little further. Looking back at some of the original studies in which it was compared studies of metformin monotherapy versus a placebo-controlled trial, patients were then asked at the end of the trial any of the side effects they might have experienced during the treatment period. That laundry list has to include everything any patient might have experienced. But then you can break that down by what percentage of patients actually experience a side effect. Let's look at this table here. Here we see 53% experienced diarrhea. Not so great. However, 11.7% experienced it on the placebo. Nausea and vomiting, 25.5%. Not so great either. 8.3%. Flatulence, 12.1 versus 5.5, getting closer. By the time we get down here to abdominal discomfort and headache, there's not really a significant difference between placebo and the metformin treatment. So what we can take away from this is that there is an association between diarrhea, nausea and vomiting, even some flatulence, and the treatment with metformin in almost the majority of patients. However, let's also remember less than 6% of the patients actually had to discontinue the medication due to side effects, that while they may have listed this as a complication of the treatment, the actual percentage of patients which experienced them to such a degree that they weren't able to tolerate it was fairly low. Less than 6%, we're talking 1 in 20. So what about serious adverse reactions which might be associated with treatment with metformin? There have been case reports of lactic acidosis, leukocytoclastic vasculitis, megaloblastic anemia, and pneumonitis. It's important to know that these serious adverse reactions, which might be life-threatening, are seen in less than 1%, much less than 1%, as listed by studies. So after discussing the risks associated with treatment of metformin, let's talk about some of the benefits. The real benefits of taking metformin is that it lowers your blood sugar, which is important in preventing the complications of diabetes mellitus. Well, often when we talk about the complications of poorly controlled diabetes with mellitus patients, or if they were to search them on the internet, they just see a long list of things. There's retinopathy, macular edema, coronary artery disease, peripheral artery disease, glaucoma, infections, even death. However, they don't have any numbers to tie this to, or they don't really understand what are the odds that this might happen to them if they don't act and get control of their blood sugar. There are many studies out there which tout the benefits of control of chronic hyperglycemia associated with diabetes mellitus, but I just wanted to highlight a few which were truly associated with outcomes which Mr. B would probably feel are important. So this one here. This study shows that increased hemoglobin A1C was associated with an increased risk for all-cause mortality and heart disease mortality. Here they were comparing groups of people with a hemoglobin A1C greater than 8% versus those which had a hemoglobin A1C less than 6%. So all-cause mortality in the group which was with hemoglobin A1C greater than 8% was 2.59 times as high, and heart disease mortality was 3.38 times as high. I think if you told anyone that their risk of dying was 3 times as high for not controlling a condition, it might give them some pause. Here's a study that looked at patients with diabetes and the effect that increased fasting blood glucose levels had on the risk of ischemic stroke. It was a prospective cohort study where they looked at 3,000 patients for almost 7 years. What they found was this: if you have diabetes and your fasting blood glucose is consistently elevated, they had an increased risk for ischemic stroke. Their hazard ratio was 2.7. For vascular events, hazard ratio of 2. If you have diabetes, but you are controlling your blood glucose and you do not have that consistent elevation of fasting blood glucose, there was no increased risk of ischemic stroke. The hazard ratio is only 1.2, and for vascular events, hazard ratio of 1.3, neither of which were statistically significant. Here's another study showing that hemoglobin A1C is associated with an increased risk of lower extremity amputation. So a systematic review looked at almost 100,000 patients with type 1 or type 2 diabetes. Of these 100,000, 1,200% had to undergo a lower extremity amputation. Each 1% increase in your hemoglobin A1C was associated with a 44% increased risk of amputation in patients with type 2 diabetes. When it comes to saving life and limb, it has been demonstrated in the studies that control of your diabetes can do just that. One final study that looked at intensive management versus routine management of diabetes mellitus. Now, granted, this goes a little bit beyond just treatment with metformin. This assessed a lot of the aspects of controlling for diabetes mellitus. So it was a randomized trial. It was only 160 patients, but they followed them for a long time. There was intensive management versus routine management. In the intensive management group, they were treating their hypertension. They were also giving them aspirin if they had ischemic heart disease. They made sure that their hemoglobin A1C was less than 7% and made sure that they were receiving anti-hyperlipid treatment. One of the big take-homes of this study, after following them for 13.3 years and comparing the intensive treatment versus the usual care, 30% of the intensive treatment arm had died. 50% of the routine management had died. This once again just goes to emphasize how truly important control of the diabetes and its complications can be. So, in summary, let's finish with a side-by-side comparison of the risks and the benefits of being treated with metformin for diabetes mellitus. Big take-home for the risks, you're going to see side effects. And the side effects might be fairly common. GI side effects were listed from 5 to 50%. These GI side effects might be diarrhea, might be flatulence, might be nausea and vomiting. However, it's got to be remembered that in less than 6% of people was this so severe that they couldn't tolerate the treatment. Headache was also pretty rare at 1 in 20, and serious complications were vanishingly rare at less than 1%. The benefits seen from treatment with metformin, whereby you might decrease your hemoglobin A1C by 1 to 1.5%, are palpable. We're seeing a decreased risk of stroke by 3 times, a decreased risk of amputation by 2.5 times, decreased risk of cardiac death by 3 times, and overall mortality by 3 times. This is a significant improvement, but still, one must simply inform the patient, let them know really what be going on with the side effects and really the benefits they might expect over the next decade, 15 years of their life, and allow them to make the decision themselves once they have become properly informed. In the spirit of a risk-benefit analysis now performed with further information, we can present Mr. B with a truly educated option of whether he desires treatment with metformin or not. Let's finish with a quote from Sherlock Holmes. "It is a capital mistake to theorize before you have all the evidence. It biases the judgment." Thank you for listening. I hope you enjoyed this short presentation, and here are a list of references. Thank you. Bye.